And what kind of life are you going to give the patient if the knees are replaced beautifully, or if you've done your reverse shoulder replacement, but the patient's ankles are fused so the patient can't walk and the patient's wrists are fused. So regardless of the fact that you took away the pain, what is the quality of life? Now, importantly, when you treat, you also need to know what is not RA, right? So that's my basic stuff. So this was a 54-year-old lady who came with duration. I'm going to keep it purely clinical. I don't want didactic lectures, theory, and so on and so forth. Progressive finger deformities, there was pain, some days bad, some days okay, stiffness, mild rheumatoid factor positive, and what do you think this is? There are deformities and so on, but the interesting part was that this was primary osteoarthritis. This wasn't rheumatoid arthritis at all. The challenge comes, the bitch of it is when you get something like this. And when you get something like this, what are you going to do? Are you going to be able to treat this? But the important part here is, once again, this is not rheumatoid arthritis. This is a scleroderma. If you get your diagnosis clear, is when you're going to know what direction to go in, because otherwise you're going to miss the boat anyway. This is a 33-year-old female who had joint pain, swellings, had been to not only physicians, orthopedic surgeons, and in fact, multiple physicians. So this was way back 15 years ago, where even our knowledge has really evolved in the last 15 years. So methotrexate 2.5 milligram 5 days a week, exactly opposite of what Raj Kiran was just telling you. So Monday to Friday, methotrexate was given 5 days a week, hydroxychloroquine, sulfasalazine, no improvement, leukopenia, patient had altered liver function, lot of rash, lot of oral ulcers. Everything that Raj told you was all there in this patient. Look at the hands. And if you notice a little closely, you will realize that there are skin lesions. And this was a dermatomyositis. This was really not a rheumatoid arthritis at all. Mind you, every rheumatic disease is going to come to you with hand joint pains and knee pains and ankle pains. That doesn't mean every pain in every finger and every toe is rheumatoid arthritis. This is very simple. So I'm not going to waste your time on it because I have exactly 10 minutes left. But this is primary erosive osteoarthritis, and the synovium is bulging out from the Burkhardt and the Haberden's nodes. And for donkey's years, there was no treatment available for this condition at all, isn't it? And it might give you some pride to know that the first man who actually held the baton for trying to treat osteoarthritis as a rheumatic disease is from India. He's in Lucknow. He's now in his 70s. He actually started it, and even we rheumatologists used to wonder, kya is वैसे खाएंगे? Every year he talks about this topic, but his passion continues. Now we are actually exploring biologics even for primary erosive osteoarthritis, because at the end of it, the pain is not bad. The progression is slower, but the disability is the same. This was a 34-year-old male, asymmetric arthritis. After gym workouts, developed low back pain, so he was badly disabled. One ankle, one knee, as you can see, quite swollen. There are some skin lesions, and he had this recurrent episodes of slip disc pain. But then, as Dr. Kavita was talking about this gentleman, now mind you, don't think that spondyloarthropathy will not have finger joint pains. So if you have the enteropathic variant, if you have the psoriatic variant, if you have the reactive variant, you will get finger joint involvement. And unless you have your classification criteria. So if you want to know what is not RA, this is what my teacher used to teach me. Think laterally. First learn what is RA so that you know what is not RA. And master RA so well that the moment it deviates from the rules that you have imbibed in your brain, you're going to know, okay, let's look for something else. This was a young girl, severe pain, multiple joints painful, but this finger was disproportionately painful, and she was feeling a little weak and feverish. You can see the sausage kind of, the fusiform kind of a finger. Now, a rheumatoid arthritis will not have the shape of a fusiform finger, so the moment you get that, you know you need to do something else. And this was tuberculous dactylitis. By the way, this patient had been started on methotrexate before I saw them. This is simple, so I won't waste your time on this, but when you look at this and this gentleman comes to you and there's this history of alcohol and there's this history of toe deformities and relapsing remitting pain, yes, you're going to say this is acute profacious gout, you're going to give the entire diet restrictions and all of that. But what happens when you get a chronic profacious gout like this who looks like a rheumatoid, behaves like a rheumatoid, the deformities are as bad, and when you do x-rays you realize that the joints are eroded. That's when you need to master the erosions on the x-ray of the rheumatoid arthritis versus a gout to look at the overhanging edges even out of, or the erosions that happen in a chronic profacious gout in the end. And this was total gout, okay? And this gentleman, just for your information, was not an alcoholic, was a pure vegetarian. This was a genetic predisposition. This was a 16-year-old boy with progressive stiffness, deformities of the fingers and the other joints, and his rheumatoid factor had been done twice, which was negative. Early morning stiffness was about 20 minutes, and he had been having slightly stunted growth. The moment you get something like this, even I don't touch this patient, I send them off. This is a spondyloepiphyseal dysplasia. There's nothing really that even a rheumatologist is going to do out here. This gentleman had pain and stiffness in one hand, so the onset was asymmetric. All of us rheumatologists talk about the fact that you should have bilateral symmetric, small and large, blah, 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 whatever it is. But is it necessary? V.R. Joshi, my teacher, used to say, diseases do not read textbooks. So don't expect that a disease is going to behave like this, which means that if one joint comes in first and the other joint comes in later, that's possible, right? The disease has decided on its own what it wants to do. And hence, this gentleman came with first one hand swelling, fingers, hands, wrists, NCPs. The rheumatoid factor was positive, and later the left hand started paining. And the background history was he was a diabetic and he had a left-sided cerebral tumor operated 2 years ago. Ring the bell? So this was like an RSDS. There was a left-sided cerebral tumor which was operated, and if you correlate, you will realize that a few weeks later is when the right hand got involved. Now add to that the fact that the patient was diabetic. So when you turned the hand around and you looked at it, there was overuse of the opposite hand now because the right hand had become like this and the namaste sign was positive. And when you looked at the other side, there was flexor tenosynovitis because of the diabetic keratopathy. So this is completely misleading. This gentleman was treated with methotrexate, leflunomide, everything that Raj said. He just made my life easy. I didn't know I would have to speak after him. Just made my life easy to tell you, and it's just going to go on in my tomorrow's talk about what not to do in RA. But methotrexate 7.5, leflunomide given in combination, patient developed jaundice and leukopenia. Thereafter, patient was given methotrexate plus sulfasalazine together along with hydroxychloroquine, leukopenia, liver enzymes elevated, hence stop. Then given methotrexate 5 mg, leflunomide 10 mg. No washout given. Every time this was changed periodically. And this is how this gentleman was. But if you had to just focus on the cuticles of the nails, you would realize that this is a little more than rheumatoid arthritis. And then once in a while when a patient comes to your joint pains, it helps to look at the toes. So this was a psoriatic arthritis. This was not a rheumatoid at all. And a psoriatic arthritis will come with its component of liver fibrosis, will come with its dysmetabolic, they have a metabolic syndrome as well. So they have a dyslipidemia, sometimes they are diabetic and so on. So this is to give you a flavor of what we rheumatologists do in the OPD. It's not treating joint pains, it's doing what not to do is more important than knowing what to do. Every textbook tells you what to do. But it's a teacher who tells you what not to do. So this was long-standing finger joint pains, no swelling, but the deformities had developed over time, and this patient came to us after some 10 years history. So that itself should tell you, if it is 10-year history and the patient is still active, then there's something else going on. So this was ligamentous laxity because this was Yaput's arthropathy.